In September of 2003, the body of an unidentified white male was found wrapped in plastic garbage bags in an industrial section of the Bronx. The deceased was in an advanced state of decomposition. The individual was 5 feet 10 inches and, based on anthropological analysis, estimated to be between 40 and 60 years old. He was notably wearing a light-colored Brooks Brothers shirt with the laundry tag labeled Felix. And here I am using art as an additional dissecting tool to gain greater understanding of this individual and what he had gone through. Metallic implants in this case and in general use throughout the body can be helpful in the identification of unknown deceased. Larger implants such as those for the hips or other spinal implants have serial numbers. These titanium plates and screws that are used on this skull do not have numbers because of the small size. The police investigation of this man's death remains open. The New York City Medical Examiner's evaluation has left the cause and manner of his death as undetermined, but they feel that the probability of homicide is low. Of particular interest in this case is evidence of significant prior neurosurgical intervention.
So we have new information that may help us to identify this man. We have his full dental records. We know that he had reddish hair, he had a beard, but we don't have fingerprints. And we're hoping this may provide some leads.
Well, cranial plates and screws are commonly used to affix the bone flap to the calvarium, which is a skull, after craniotomy, brain surgery, or trauma. Based on the configuration of this bone flap and the accompanying plates and screws, it's possible to suggest what type of surgery a person has undergone and to assist in ascertaining the medical history of this particular individual. There's evidence of wiring at the right orbit inferiorly and also laterally at the orbital zygomatic process, as indicated by the red arrow. Additionally, there are plates and screws overlying the anterior wall of the frontal sinus, that's the forehead above the eyebrows. The blue arrow shows evidence of bone growth and remodeling of the burr holes. Also noted was that the nasal septum was asymmetrical, probably a result of trauma to the nasal area.
The craniotomy that we see in the figure could represent a number of different etiologies, but overwhelmingly, perhaps based on my history of working with you in the Bronx, it does seem like he suffered some kind of traumatic insult. And that's evidence, I think, because he has facial involvement as well as cranial involvement.
My first impression and the main impression is that it is traumatic. And this can be evident from the as a complex involvement of the cranium and the facial bones. There is a right frontal linear fracture, healing linear fracture, in addition to the left supraorbital pieces that's separated, that cannot be explained unless it is a kind of trauma that caused these small fractures that need to be fixed. Especially you can see it on the left supraorbital area. Of course, one of the consequences later on could be the patient has some frontal lobe injury, epilepsy maybe, and if there is no evidence of homicide, I thought about maybe the complication of injury can cause epilepsy and personality changes. It could be could die from any cause, not necessarily homicide.
We are looking down into the frontal region of the skull, and you see the yellow arrow indicates that there's an area of bone erosion just adjacent to on the orbital roof. That's the yellow arrow, and the pink arrow indicates a remaining suture through the dural tacking holes.
And in some ways, the cranial procedure is very reminiscent of a fairly standard neurosurgical approach to a tumor that would be at the base of the skull. And the erosion of the bone might also corroborate that, as does the tack-up suture. Alternatively, this could have been a fairly extensive exposure for just something like a spinal fluid leak, which could be related to trauma.
The yellow arrow here shows exactly that area of bone resorption in the frontal sinus region. Now, when you look in the inside of the skull, there is no frontal sinus. So it was either obliterated or it was very small. Plates and screws have been identified as having been manufactured by Medtronic and appear to have self-drilling tips, possibly originating in the mid to late 1990s. So now we've got kind of a time frame. Some of the screws you'll notice are blue colored, and these are presumably rescue screws which have slightly larger diameters than the silver titanium screws. Additionally, at the medical examiner's facility, a CT scan was done of this skull, which didn't lead to any further information. Each painter has her own style and brush marks. Each surgeon is unique. This skull carries the mark of his surgeons, and I knew from the second that I looked at this skull that I had not done the surgery.
This is not my signature, but moreover, I can say that it doesn't represent the signature of any neurosurgeons that I've worked with directly or indirectly. We do all tend to have our styles, and this is a fairly unique one. That being said, this also represents an inflection point in medicine. During my early, in neurosurgery, during my training, we used almost exclusively alternative mechanisms for putting the bone back together after our surgery. It was just near the end of my training in the early 1990s when we started using these kind of cranial plating systems.
When I saw the pictures, I said, no, it's not my style. In fact, I usually take photos intraoperatively when I finish fixation, like I'm drawing on a canvas. This is why I love these photos, in fact, because as I told you before in the discussion, it's like a unique painting that we paint, like some artistic structure on the curvaria.
If we feel that this person had some kind of derangement in the frontal lobes, it leads to issues which may have impacted upon his death. Dr. Hadi mentioned there may have been a seizure disorder, there may have been some judgment errors, there may have been a whole host of things. There may have been a postoperative infection, which then led to the bone resorption. We just don't know. One thing we do know, though, is that the surgery was very complex. It was probably not done at a community hospital, and it probably involved not only neurosurgeons, but because of the orbital fracture, maybe oral maxillofacial or maybe plastic surgery.
I actually was involved in one of the early studies where we looked at whether to do early or late craniofacial reconstructions in the setting of trauma. And there were two really interesting findings about that. One was that even though the frontal lobes are critical, in patients that did have craniofacial trauma, their outcomes were remarkably better than patients that had similar kind of traumas in other parts of the skull, because the face absorbed an awful lot of the trauma, as did the skull, rather than the brain doing it. And so these patients did remarkably well. We also found that we could do early craniofacial reconstruction and do it safely and effectively, where it was felt before that you had to wait for several weeks.
It is evident that this person received the highest level of medical care from his neurosurgical team. It is hoped that the same neurosurgeon may once again intervene on his behalf to bring this cold case to final resolution. In the meanwhile, we are left with an operated skull of plates and screws, his surgeon's work of art.